Testing. Oh, yeah, good. Okay. All right, y'all passed that test. Good afternoon, everyone. Thank you so much for taking the time to come and hear our presentation this afternoon. For those of you who aren't quite sure what you're here for, we are doing a presentation on dementia, aging versus issue. For those of you who don't know me, my name is Jennifer King, and I am one of the social workers. I work with residents A through K, and then I'm going to let the rest of the panel introduce themselves, and we will get started.
Hey, I'm Holly Wenger. I'm the nurse practitioner.
Dr. Gwen Boer.
And I'm Dr. Milta Little. And so I'm gonna, there we go. So that's those who is here today. And Carissa is not able to be with us, but she's the other social worker as well that some of you may know. So let's go ahead and jump in to what we're going to be talking about today, which is what happens to our brains as we get older, both what we can expect versus what is not expected with aging that should come to our attention. So as we age, our bodies continue to change. Our bodies change throughout our entire lifespans. That does not change as we get older. And so change is inevitable, including our brains. So what we can expect to happen is that there are some structural changes. So you see a picture up there of a typical brain at age 42 and a typical brain at age 82, where you can see that there is some change, including the loss of some of the size of the brain mass, the areas that are darker where the fluid is, and you can see those areas generally are larger. But that does not mean that this is abnormal. There are just some structural changes as well as some biochemical changes that occur as we get older as well. And what does that mean? Well, we know, and you all could probably tell us better than I could tell you, that our brains slow down. What that means is that as we age, we can still learn things. We can learn throughout our entire lives. It just might be a little bit harder than when you were younger, might take a little bit more time. Our brains have never liked dual tasking. So multitasking is something our brains don't love to do. We might be good at it and pride ourselves at it, but our brains don't love that. And that gets even harder and harder as we get older, to do more than one task at a time. So that's harder. Learning something like a new piece of technology might be a little bit more perplexing as we age. And that very strange phenomenon of where you walk into a room and you forget why you walked in, that happens throughout our whole lives. My kids do that, but it happens more frequently as we get older. Those are all expected as we age. Another common thing that we often hear is, I'm not good with names, never quite have been, but it's even worse now. That is also something that's very typical as we age. And generally, those are the things that don't strike my brain as, uh-oh, I'm concerned. However, there are some things that would tickle my brain to say, uh-oh, I'm concerned. So that would include some signs of what we call mild cognitive impairment and or dementia. So those are two distinct categories of things that can be related, and they may be a spectrum of each other. So those two conditions are when there are changes in the brain that are not from expected or typical aging. Mild cognitive impairment is when people, usually they notice it in themselves, it may be a loved one or a close friend, say, something is not quite right. It's a lot of times short-term memory slips, repeating oneself often. And when you come to see us for your annual visits or for another visit, we might do one of those screeners, and we might be able to detect, okay, there have been some changes from how you would have performed 5, 10, 15 years ago. However, you're still able to do all of your day-to-day tasks independently. You can still drive, you can still manage your medicines, you can still do your finances. Might be a little bit trickier You might have to put some things into place in order to do it well, but you still can do those things. That's mild cognitive impairment. Those folks are at higher risk of this progressing on to develop dementia. Although if we catch it at this stage, sometimes there are things we can do to slow that down and keep that from progressing. Dementia, on the other hand, is when we notice those brain changes, we can detect it on our screeners, maybe other people have started to notice a little bit more, and it's now affecting your ability to do your day-to-day things. So maybe now it's time to retire from driving, or a loved one has taken over the financial management, maybe making some slips on medications where you need some support. And over time, needing more and more assistance with all the day-to-day things, including getting dressed, getting meals, getting to the bathroom, those kinds of things. That's dementia. And so those are distinct. They're not normal with aging. And so that is why it's really important that those concerns get evaluated. And that's why we do routine screens to look for that, because there are things that we can do to address that. There are various different types of dementia. So dementia is the umbrella term of these changes in your brain that affect your ability to do your day-to-day tasks and affect your memory. So the most common one that people think of is Alzheimer's disease. That's the one that has been described the most. It's out, and we have the Alzheimer's Association. It's what people know the best. Alzheimer's disease is caused by a very specific protein called amyloid. You don't have to remember all of this, but I'm going to distinguish the different types because this is how we think. And then that amyloid is overexpressed in the brain and then causes a cascade of problems that can lead to essentially scar tissue in the brain and causing dementia. But that's only one type. So it is important for us to distinguish because these may look different from each other, and the way we would manage that as a team may be different. So the next one on the list is frontotemporal dementia. This is a different protein that causes frontotemporal dementia. Have any of you heard of the story of Phineas Gage? I see some head nods. So for those of you who have not heard of Phineas Gage, he was a young man who worked on the railroad many years ago. And one day there was an accident and a spike drove through the front of his brain. So a railroad spike went clean through the front part of his brain. He survived. He went back to work, and his colleagues started noticing, ooh, something is not right. He is very different. He's aggressive. He's had personality changes. He has behavioral issues. He became sexually inappropriate, and he could no longer work because of that. And so he was one of the first to be described as having a frontotemporal disorder. So that's kind of the story of Phineas Gage, is how we in healthcare kind of remember what this looks like. So it looks very different from Alzheimer's. Typically occurs under the age of 60. But sometimes people can develop it in slightly older ages. It's very unusual for people in their 80s or 90s to develop classic frontotemporal dementia. There are two types. There's the behavioral Phineas Gage variant, and then there's the language variant, or primary progressive aphasia, is something that maybe some of you are familiar with. And that is predominantly word finding. So issues with language, communication, memory is not very predominant in that one. So that's different kind of protein. Then there's Parkinson's dementia, and I'm actually going to loop that down with Lewy body dementia because those are caused by the same protein. For those of you who are interested in the name, it's the alpha-synuclein protein, and where it gets affected in the brain is what it will then look like. So two of the alpha-synuclein pathologies would include Parkinson's disease, which is kind of the typical of what we think of with the kind of the pill rolling tremor, stooped posture, shuffling gait. A pill rolling means it looks like somebody has a pill in between their thumb and their fingers, kind of slowly rolling it back and forth. And over time, people can develop dementia. Not 100%, but people can. Related condition is Lewy body disease. Same protein, that's in more places of the brain. That is predominantly memory. It can look a little bit like Parkinson's too. These people also tend to fall quite a bit because they have trouble regulating their blood pressure and their ability to walk safely. And they tend to, both of these conditions also tend to have issues with sleep. And so that can be a predominant symptom that comes to our attention first, is some sleep issues. So that's what we ask questions about, all these different things. Vascular dementia typically occurs after people have had strokes, or if they have a lot of risk factors for strokes, like high blood pressure, high cholesterol, diabetes, and they've had those for a long time, maybe not well controlled, maybe just they've had it for a long time and it's affected the blood flow to the brain. Tends to look a lot like Alzheimer's disease, but again, it depends on where in the brain that has the blood flow has been affected. The last one on the list here is the one that looks most like Alzheimer's disease, and that is one that really has only been fully described since about 2019, was when the big paper was published on it. It's called LATE, L-A-T-E, LATE. It has a wonderfully fancy name, which is I always have to peek, limbic predominant age-related TDP-43 encephalopathy, but we just call it LATE. I like that it's called late because it typically is the one that occurs in much later ages. So this is the one that tends to come on people in their 80s and 90s, tends to be slowly progressing, looks a lot like Alzheimer's disease, but if we started medications, people typically wouldn't respond to it. It wouldn't make a difference because it's a different protein. So this protein is actually the same protein as the frontotemporal or Phineas Gage kind of dementias, but it just is affecting the brain differently and at different ages. So it's a very different syndrome, but it can cause problems. So my former boss used to say that there are over 130 different types of dementias. I'm not sure that I fully believed him because he could never give me the full list, but there are dozens of others, but are far more rare. These are gonna be the most common. So that's my big spiel overview on these, and I will hand it off for the next part.
Okay. So now we're going to talk about the diagnosis and treatment of dementia. So first, if you were to come to a doctor's office complaining of memory problems, then we would do a physical exam, of course, and first we'd take a history, and we would want to know the different things that Dr. Little was talking about that might distinguish the different types of dementia, the time course of what you've noticed, what kinds of problems you've noticed. Is it primarily word finding? Is it memory? Is your spouse saying that you're repeating things all the time? What are the different functional issues that you're having? So we would take a history, and then we would do a physical exam. The physical exam would help us to distinguish between the different types of dementias and also think about if there could be some reversible things that we could treat. So we would look for signs of Parkinson's disease. We would look for any weakness on one side of the body that might point to a stroke in the past. Other evidence of vascular disease, like diminished pulses in the feet, might indicate some vascular disease in the legs. And if you have vascular disease in one place of your body, you probably have vascular disease in other places of your body. We would watch you walk and see if there are signs of Parkinson's when you're walking, or if your feet are kind of sticking to the floor. Then there's another type of dementia called normal pressure hydrocephalus. We would look for peripheral neuropathy because that could come with vitamin B12 deficiency, which is one of the reversible causes of dementia. So if we found signs of that, then we would definitely do a test and see how much vitamin B12 you have and if you need replacement of that. We do blood tests anyway if we're finding some memory issues, and we would test for vitamin B12. We would test your thyroid because low thyroid can relate to memory. and we would just look in general at your electrolytes, kidney function, liver function. And if we had somebody who had a lot of risk factors, we might test for syphilis or HIV. We would ask about your history in the past. So people who have had a lot of head injuries have a higher risk of developing dementia, so we would ask about that. We would look at your medications because certain medications increase the risk for memory problems. There's a category of medication called anticholinergic medications, and those can cause memory issues. So we would make sure that you're not taking those medications. Other medications like sedatives, sleeping pills, things like that can also cause memory issues. So we would take a good medication history and make sure you're not taking any medications like that. And then we would think about mental health, because depression and anxiety can mimic some issues with memory. So a person who is depressed will have a harder time with the memory test. They have trouble concentrating. Same with somebody with a lot of anxiety. So we'd make sure that we're treating the depression and anxiety. And then we would do a cognitive test. So most of you have probably had the cognitive testing that we usually do, the MOCA. There's also one called the SLUMS. And then there's shorter ones that just have the clock drawing or remembering fewer words combined with the clock drawing. So in some way, we would do a screening test for your memory. And then talk about whether to do imaging tests. So if there were some focal neurologic findings, like weakness on one side of the body, then we would probably want to do a scan and make sure there was nothing else going on. Regardless, we can talk about doing an MRI, because now we can do an MRI that measures the volume of the different parts of your brain, and different parts of your brain would be affected with different kinds of dementia. So that would help us to know if you have Alzheimer's disease based on the size of the different parts of your brain. And then we would think about or talk about whether we would want to do a PET scan, because like Dr. Little said, amyloid is responsible for Alzheimer's disease, and we can detect amyloid with a PET scan. So if we found amyloid on a PET scan, then that would mean that you have Alzheimer's disease. So if you wanted to know and there were concerns with your memory, then we could talk about a PET scan. And after we did all of that, then we can think about treatment. So there are 3 different types of treatments that we have. We have acetylcholinesterase inhibitors and a medication called memantine, which works in a different way. And then the intravenous medications, which are the infusion monoclonal antibodies that get rid of the amyloid. So the first 2, we don't have to have any imaging to prescribe those. And all of the medications, even the infusion medicines, they slow down the decline of the memory loss. They don't reverse things. You would think, and when the infusion medicines first came out, we were hopeful that you get rid of the amyloid, then everybody is better. But it seems that it doesn't happen that way, and probably because the amyloid has caused some damage already. So they're studying it in people who are much earlier in the disease to see if we get rid of the amyloid earlier, can we really prevent it from progressing or reverse things a little bit. Then we also do symptom management of other kinds of things that happen with the different kinds of dementias. So we want to help with the sleep problems or any hallucinations, or treat the depression. any other symptoms, then we would do that.
Okay. Next, we're going to talk a little bit about how dementia might affect you as an individual, because we're all unique people that have different personalities and different structure to our lives, and different other medical conditions in the background. So to talk about your social situation, somebody that starts to develop trouble with their memory, if they're already living with a family member, spouse, partner, or other family, they may have good support in place already and sort of not have to face any dramatic changes early on due to their good social support, whereas somebody that's living alone may need help sooner, and we'll get to that in a little bit. Other things, like I referenced, having other medical conditions going on in the background, that can greatly impact one's experience of dementia. So for example, if you're somebody that has different medical conditions going on in the background and has to take a lot of different medicines, that might be more of a challenge up front if you're faced with dementia, because you're balancing taking care of yourself in other ways. Whereas somebody that may not have as many other coexisting conditions and may not be taking very many medications, it may not impact them as much in that realm. And we talked about earlier the hallmark of dementia being that you lose your ability to do some of those independent functions, such as driving, managing finances, managing medications. All of that looks different, one individual to the next, and who they have in their life as a support person, and the rate of progression that they experience in their disease process. So we are very big on supporting each of you as individuals and looking at kind of your overall picture to help manage memory issues and dementia should they come up.
Okay. So what does this mean? You have a diagnosis. Your diagnosis might be mild cognitive impairment. It has not been affecting your day-to-day. You may have a diagnosis of dementia. What does that mean for you? So living here at the Forest, you're very fortunate in so many ways, but you also have the support of not only your community, which I look around and just see what type of vibrant community we do have. You also have social workers, you have rehab staff, you have medical teams. Being here in Durham, we are the city of medicine. We have access to Duke and UNC, much better situations than those who may live in more rural areas or areas that do not have the access that we have. So here at the Forest, we are a team. So residents are a part of that team. Residents, if you have a spouse, a partner, that person is part of the team. If you have family, whether that family lives here locally, whether your family lives out of state or out of the country, they're part of the team as well. We have an interdisciplinary team, so that would be nurses and social workers. Can't forget us, we're here. So what happens? A lot of times if someone does receive that diagnosis, we want to start talking with them early on. I have residents who say, well, why do you want to talk to me? You want to move me? That's not exactly what I'm always here to do. But what I want to do is start looking at things that are your strengths and some things that may be challenges. So as things progress, we have a relationship. We can look at those challenges together and say, okay, so this is becoming an issue. What can we put in place to help this issue? One thing could be rehabilitation. We have an excellent rehab program here working through Legacy. Great physical, occupational, and speech therapist. I was talking with another staff member recently, and I said, oh, that person, I think, is getting some speech therapy. And she said, well, I mean, they talk okay. So I don't think a lot of people really understand what therapy can do here or anywhere. So with physical therapy, if someone is diagnosed with Parkinson's or other types of dementia that may affect their person's ability with their walking or safely navigating areas, physical therapy can help with those things. Occupational therapy. They're not here to make sure you have a job, because a lot of times that's what people think of OT. But they're here to look at things like medication management. Are there systems that we can put in place that if you're having a little bit more trouble with your higher level executive functioning, can we work with someone to have a pill box set up? Or do we need pill packs that would help you be more successful in that area rather than trying to manage pill bottles? So those are things that occupational therapy can also work with. They help people, even like in transition, if a resident moves into the health center and assisted living, maybe they're in a completely new environment. How do I know where my clothes are? How do I organize my environment? They can help with all those kinds of things. They can help even organize an environment when someone is still living in an apartment or in a cottage. It can help someone maintain that independence longer by having their involvement. Then there is speech therapy. So speech therapy is very unique. They look at a lot of different things. Yes, they do work with people on speech and speaking, and they work a lot with people who have Parkinson's disease on the volume level, because that's something that can change. So they work on techniques to help increase their voice volume. But they also work on things called external memory cues. I can't keep track of my appointments. I've tried, but I can't remember where I put them. I used to write them down on a piece of paper. It's all over the place. I'm usually good at taking care of things. I just can't remember to take my morning medicines. Well, there's things that speech therapy can work with to help people to remember those things. Whether it would be we have all the type of technology you can imagine. So it might be setting alarms or, having different things set up in that way to help residents. And then also sometimes with some of the different forms of dementia, there may be swallowing issues, and speech therapy works with swallowing. So there might be, looking at someone's diet and the texture of their food or the type of thickness of their liquids. They do a lot of those types of things too. So really working with all three therapies is really a holistic approach to how can I walk better? How can I think better? What can I have in place to help me when I can't think better? So that they're a big part of the interdisciplinary team as well. And then there's social work. So we are case managers and we're resources. When residents, you may have a spouse that you're concerned about. If something happened to me, my spouse does have memory issues, and what's going to happen to them? If I get sick and have to go out to the hospital, who's going to follow up? Who's going to be there to assist? That's where social work can come in and help. We can meet with you ahead of time and talk about scenarios. We get to talk about all the morbid stuff in life. So if something did happen, what could we do? Is there a local family member that we call? Does the person need help getting to the health center briefly while someone comes from out of state to stay with them? So many different things can happen. But having that information not only gives the resident who may be sick a peace of mind that their loved one's taken care of, it also helps the forest know where do we need to jump in and provide support. Because that's what we're here for. That's why residents move to a retirement community, to know that there's support when it's needed. So just looking at making sure that as social workers, we're going to implement an ongoing plan. Be there with you as changes occur, look at interventions that are appropriate, and yes, there may come a day that there's a discussion about a transition to the health center, whether that would be either memory care or assisted living or skilled nursing, we look at all those things. But what I always tell residents, and Carissa does the same, unless it's an emergency, it should not be a surprise if you do have to move to the health center, because we are working with you throughout the whole process as life changes to see what we can put in place to support you during that time. I mean, we have home care services, whether they're through the forest and home or through home care outside of the forest. We would help you coordinate and talk about the pros and cons and, the positives and negatives and what, might be in your best interest. That's what we're here for. So we work very closely with our medical team. Other residents have connected me or Carissa with their outside physician if they have a primary physician outside of the forest. We work closely with therapy and, with all of our other departments in order to really, we want to be there and be a support and a resource for the residents as life changes for you. I hope that you have found this information helpful. We will have a time for questions, and what I'm going to do, since we're taping this, is I'm going to take this microphone and hand it to those who have questions to give time for these lovely ladies to answer those for you. So, questions? I'm going to bring that to Mr. Elman.
It's not a question, but I just want to make everybody aware. This morning, I went to Duke to see if I could qualify for a research study on mild cognitive impairment, exactly what they were talking about. I went through a number of the tests that were presented to us this morning, and the good news is I flunked. Okay. But if anybody is interested, you think you may have impairment, send me an email and I'll provide you the information on who to contact about the study.
Thank you. He is the fifth member of the panel. Other questions? Now, I hope y'all didn't forget what we just said, because then we have a whole other issue going on. All right. Oh, yes, Mrs. Elman.
I know that a lot of people here are worried about this exact same thing. Are they going to force me to go? What do I do if they tell me I have to go? Answer that, because we've experienced that with people here.
So that's always one that is tricky. So number one, I think one thing that Chris and I have really tried to do over the years is build that relationship, to always be upfront and let people know what to expect. And if we do have concerns, to let people know we might be heading towards that. With most people, it works well. With others who may not always have as much support locally, it can be a little tricky. Or they may have great friends that can help them through that process. When you moved to the forest, you moved into a retirement community. So we are a community that offers care beyond independent living. And for many people, it's a comfort knowing it's there, but you never want to have to use it. Am I correct? I mean, let's all face that, right? We may have our funeral arrangements made, but we're not really looking forward to the day that we get to, cash those in. So yes, I hate to use the word forced, but there is a contractual obligation to ensure resident safety, and so we can, as a interdisciplinary team, so Dr. Little would be a part of it, Dr. Bohr. We would contact the person's physician. We would want the person and the family involved to really talk through it and explain what the concerns are and what it looks like to make that move. So yes, we do have the ability to have someone move to the health center. Saying that, people do have the right to leave the forest if they feel strongly that this is not the time for them to move or that they don't want to move. We've had people who have chosen not to live at the forest after that. So I hope that answers your question. Yes, Mr. Small.
Are any of these forms of dementia hereditary?
Yeah, so that's a tricky, it's a complicated answer to a simple question, I should say, because yes, many of them are hereditary in the sense that it becomes a risk factor. So the one that we know for sure has a strong familial link that if your parent had it, sibling had it, you will get it, is Alzheimer's disease under the age of 65. So early onset Alzheimer's disease is usually familial. It has a strong genetic link. That's the one that we are studying most heavily in research to understand that, so that if we can treat that, then we kind of know what to do with what we might call wild type Alzheimer's, where it's a little bit more unpredictable. So, I have Alzheimer's disease in my family. Does it mean I'm going to get it? No. It just means I'm at higher risk than my friends who do not have it in their family. And so it is a risk factor along with many other risk factors, particularly for Alzheimer's, for late, for Parkinson's, Lewy body disease. Those are all, yes, there may be a genetic component, but it doesn't guarantee, and it's a risk factor among others.
Other questions?
Dr. Burr, you had said that the PET scan is used to detect the amyloid plaque. In the study that I attended this morning, they use MRIs. What's the difference in detection from MRI or PET?
So the MRI usually is done before the PET scan, and it looks at lots of things. So it can tell the volume of the different parts of the brain, and when different parts of the brain are smaller than normal, it could mean different types of dementia. It can pick up some strokes, prior strokes, small microvascular changes that are more diffuse and consistent with cerebral vascular disease, or if there's some structural abnormalities or a brain tumor, we would find that on the MRI. So we normally do that first. There's also could be some microhemorrhages that could mean different things. So the MRI is usually done first, and then if there's a desire to look for amyloid, if a person just really wants to know if they have Alzheimer's disease, or if a person is very interested in the infusion medicine, then we have to do the PET scan.
Picking up on the decision, once it's necessary to move to the health center because of cognitive impairment, what is the process by which you are assigned a location in the health center, and what determines why you are in that location?
All right, good question. That one's for me. So, couple factors. We do have memory care, but we also have residents who have some forms of cognitive impairment living in assisted living. Memory care is mainly for those individuals who are at risk for what we call elopement. Not that they're going to run off and get married. It's a very strange term. But those people that if they left the building unattended, they could put themselves in harm's way, whether it would be, 100 degrees out, walking around in long sleeves, sweaters, and things like that. People who have to be monitored to ensure their safety whenever, or escorted whenever they're outside of their household. In assisted living, if someone still can do a lot of their own self-care, but maybe they're not doing great with medicine, So we're giving them their medicine, and they're, going about their day, bathing, dressing, toileting, doing all those things. They could be in assisted living. And most people who move from independent living move into assisted living unless their health is such that they need more care with bathing, dressing, toileting, or transfers. That's usually what we look at, because in assisted living, we don't have the ceiling lift to help people get in and out of bed if needed. And if it takes, a lot of two people and a lot of effort to get somebody up, for the resident safety and the safety of the staff, we need to look at, is skilled nursing better than assisted living?
I think what I heard you say is that the individual would therefore be placed anywhere from 1 to 5 in a neighborhood based on their physical capabilities as well as the cognitive impairment issues. Is this an appropriate question to ask? How does this work out in terms of the neighborhood concept when you have people on the floors who are cognitively able, interested, want to interact? How does it work out when they're interfacing with people who are not as capable?
Great question. So regardless of where you live in a healthcare center, whether you're in assisted living or skilled nursing, you will interact with people who may be at your same cognitive educational level, or there might be people who are not, just because depending on what's available, what's going on. And over the last 6 months, we had a transition in one household. I'll use that for example, where when a few residents moved in, the majority of the residents there were really receiving a lot of, care, and they weren't able to converse and they weren't able to do things. Over time, as some transitions happened, more residents who were able to hold, a conversation as we would be holding, moved in. So that particular household transitioned from maybe one person who was more cognizant to about 4 or 5 people who could do that. And then we also have opportunities for activities to get people to meet each other from other households. We also encourage people, if they know other residents, or if they want to, they can go eat a meal with other people from other households. We do have a few residents who have friends who live in another household. They just, they kind of made a routine. They may go have dinner with them each night, or lunch, or, once a week we get together and do those things. Our activity staff has done a remarkable job of bringing people together. Started a men's group, started a discussion group. We do art critique. So we're trying to get people to meet each other, to know that in your household, maybe not everybody is, being able to talk to everybody, but here in the building, there's lots of different people that you can talk to and get to know, and have a relationship with. So, we do try to help people get introduced to each other and get connected. Great question. Oh, yes, ma'am.
Based on what you just said, if somebody is not happy in their household and they have a good friend in another household, are there transfers allowed?
Yeah, so we are very open. If someone's in a household and they're like, I'm just not connecting in this household, but there's a room available where my friend lives, and we do try to take that into account, especially if we have other rooms in other households. Knowing residents' personalities and what people may like or dislike, we try to take that into account. And then when we're showing people those rooms, we're showing them, a little bit about who's in this household and kind of the culture or personality of the household. But yes, if someone is living in a household that they're not happy with, or if they met a resident and they're like, we've become really good friends, can I consider moving to that household if something opens up? We're happy to do that. You know, we want to make sure residents are satisfied and happy with where they're living and the people that are around them.
I know there's been a problem for a couple to live together. Has that been resolved in any way, shape, or form?
So in the health center, there is only 2 rooms in each of the households on the north side. So that's 2nd North, 3rd North, 4th North, and 5th North. Those are the 2 rooms that during construction were made that a door could be put in between them. At the time when we opened, there weren't any couples that were there to go ahead and you know, make that work for them. We did have a couple that came to assisted living, and we were going to do that for them, but then they decided not to stay. But there is the opportunity to do that. Currently, our 5 North household is not open. And then the couples that are there, there's one couple that have rooms right next to each other, and one is used as a living room and one is used as a bedroom. And the other couple has a similar situation, but by their choice, they have decided where they like to place the living room, bedroom. So, yep, we do try to accommodate, but we do have the ability to do that. We just haven't done that yet. Yes, ma'am.
This is a very basic question. I'm a newcomer here, but for 10 years I lived in Chapel Hill and was part of UNC medical system, and I have a primary care doctor, and all my doctors actually are UNC doctors. Am I at a disadvantage? Is there some advantage to switching over? I mean, it sounds like you're taking very good care of all of us, and I don't know whether that means I should change to the system here. I've heard very good things about Dr. Little. Friends of mine have been using you, and I'm very happy with I've had a primary care physician for 10 years. So is there a reason to switch to, in terms of the caretaking here?
I mean, I think we are very biased, and we would say, yes, we'd love to have all of you. But typically, if folks who move into independent, if they're from the area, have a good relationship with primary care, we would encourage you to stay with that person, the people who know you best. We do have a closed medical model in the health center, so once somebody moves there, then they would transition to one of the 2 of us, just depending on who's there that week or if you see us in the clinic. And so some folks say would like to establish that relationship before a move takes place, and so they prefer to make that switch. But the majority of people who have an outside provider will stick with that person unless something else happens.
I think there is an advantage that we know all of the interdisciplinary team members, and so we know all the resources around here, and maybe your primary care outside of here doesn't quite know that we have a really great speech therapist, really good OT, PT. Right, and they might not know exactly what we have at the Forest. So that, I think, is an advantage, that if you do have a lot going on and you do need some help, that we are very plugged in with all the resources that we have here at the Forest.
Did that help answer your question? Good. I always say, people will ask me that, and I said, as I think both Dr. Bohr and Dr. Little said, like, if you have an established relationship, that's great. Some people say, when I stop driving, I think I'm going to go ahead and take advantage of transitioning care here, so that everything that I do outside of a specialist can be done here on campus, and I just have to walk to the clinic. So some people think about those types of things. UNC, I think you all have some access to the UNC system if needed. There's a link that can be used at a physician's level. Yeah, there's
So there is a link between the electronic health record, which is Epic. It's not as seamless as with Duke, where we can send messages easily and we see a lot of the communications. It's more limited what we can see. So sometimes that communication is a little bit more challenging, but it's better than in other places where I've worked where there's zero ability to communicate. So we do work as well as we can and closely with the UNC folks as well.
With the addition of 100-plus new people coming in very soon, what is the capacity of 2 primary care physicians here to accommodate, if you're encouraging people to have you as their physicians, there must be an upper limit of patients you can accept.
Yeah, right now we have room, so we have space in our schedules, and we are trying to be very much like a concierge medical model where we give everybody the amount of time that they need and want, and I feel like we have room. We also have discussed, we work at Duke, and there's a contract between Duke and the Forest, and if there becomes a time when we need another physician, we've already discussed that with the Forest, that we would renegotiate our contract and bring somebody else in.
She ran out the door, but we also have Holly, who is such an important piece of the puzzle. So it's not just 2 providers, and so we couldn't function without Holly, and so she's a big asset to the clinic as well, and the support for you all.
Could you all say more about the potential of the treatments that you mentioned to slow down the progression of the disease process, and also the limitations of those in doing that?
Yeah, I should have said that when I was talking about the different treatments. I would say that the amount that they slow it down is modest at best. So maybe gaining 2 to 6 months of function, or if you didn't take it, you would be 6 months further along, if that makes sense. It seems like there are some people that respond better. So especially with the acetylcholinesterase inhibitors, it seems like some people don't respond at all, and some people respond very well. And then some people have that, maybe you gain 2 months. So it probably relates to the different proteins and the pathology, because when those studies were done, it wasn't clear, and they weren't doing the PET scans and finding the amyloid and targeting the medicine to the appropriate people. They were just studying dementia and in different ways. So yeah, does that answer your question?
other questions. No? Oh, one more.
There was an article yesterday in the Wall Street Journal on the subject we're talking about, and I don't know if you saw it or not, but it was emphasizing things you can do to ward off signs of dementia and so on. And much of the recommendation included things like what you can do with your diet, your exercise, et cetera. Do you have any comment on what people here should be doing in that regard?
Yeah, so we should have put that on the slide with the medicine treatments, because exercise has been shown to be better than those medicines. So exercise is very important. You should do at least 30 minutes of exercise a day. And they've studied the MIND diet, which is a combination of the Mediterranean diet and the DASH diet. So it consists of a lot of fruits and vegetables and not a lot of red meat. The meat would be a little bit of chicken and fish and nuts and olive oil. And the DASH diet is low in salt and high in potassium. So that's the MIND diet, and low in sugar, not much sugar. So that's been shown to be helpful. And the other important thing, which I think you guys are at a great advantage of here, is socialization. So socializing with people and doing things, engaging with your mind. So that's important as well.
Does me running around count for my 30 minutes?
Yeah, I think so.
I don't have to exercise when I go home. All right, other questions? All right. Well, thank you all so much. You've all been a great audience. We appreciate it.